Hello.
Hey there.
Hmm. Well, I'm just going to, since Nina got stuck, she said she apparently missed a connection in Munich and ended up somewhere. She's going to be somewhere in the air right now. We'll just kind of carry on without her. And so this will just be an open conversation, and I'll just introduce them one at a time based on the list that I sent. And so I figured that'd be the conversation, if that sounds okay to you.
Yep, sounds
Okay,
good.
good. I think that allows us for more opportunities, and we'll do that. So we'll just give it a couple of minutes, and then I'll introduce. I'll go ahead and turn off my video and so forth, and we'll get going.
Okay. Yeah, I'll just
Or
wait. I just wanted to make sure I could get in and you guys had
yep,
me in the system.
we got you. Thank you.
Okay.
Well, there you go. Well, hello.
Hey, Kenny.
Well, welcome. Well, I'm sorry that we won't have Nina this afternoon, actually. She apparently got stuck. So, but since it's noon, and I know that you have probably busy things going on today, I'm gonna go ahead and get started, everybody, if everybody is ready.
Yep.
All right,
Sounds
great.
good.
All right, excellent. Well, welcome everyone to another Cancer Active Education panel. Today, our expert panel is actually made up of two of what I say the world's leading experts in multiple myeloma, Drs. Sagar Lonial and Saad Usmani. Dr. Nina Shah was supposed to join us today, but due to airline shuffling and flight delays, she is currently somewhere in the air. I don't think Lufthansa has Wi-Fi strong enough for Zoom video yet. I want to thank Janssen Oncology for sponsoring this panel discussion today, for helping Throwing Bones achieve our mission of encouraging and activating cancer patients to live healthy and active lives with cancer. Dr. Lonial, Chief Medical Officer at Winship Cancer Institute at Emory University Hospital in Atlanta, is internationally recognized as a leading authority in multiple myeloma treatment and research. As a medical oncologist at the Winship Cancer Institute, Dr. Lonial treats patients with multiple myeloma and is a lead member of the bone marrow transplantation team and clinical trials team. Dr. Usmani, also an internationally recognized myeloma researcher and expert, is the chief of myeloma service at Memorial Sloan Kettering Cancer Center in New York City. Prior to his work at Memorial Sloan Kettering, Dr. Usmani was affiliated with Levine Cancer Center and as a clinical associate professor of medicine at the UNC School of Medicine. Both have credentials and publications that would take up all of our time today if I listed them, and they're both terrible at bragging about themselves on the internet, which made it really hard for me to make good bios. They're amazing. We're fortunate to have them today. So, gentlemen, thank you both for being here. So let's go ahead and jump into the conversation, because there are a lot of things that I want to talk about, and I want to give an opportunity to people who are either watching this today or later can also have questions that they can send out to us. And I think this is a good opportunity in delivering this in a format that's not strictly in a lecture format, so where we can maybe get into some questions about, I guess you could say, holistic treatment with regards to cancer care and treatment that helps you do your jobs better by getting feedback and information and relevant data for what's going on with the patient. There's no, as I say frequently, there's no magic Star Trek wand that you can wave over your patients and say, oh, here's the problem, let me fix that. You need feedback. You need data yourselves in order to better do your jobs. So focusing on multiple myeloma patients' health and wellness can have a significant impact on their treatment options and overall quality of life. Multiple myeloma is a complex disease that not only affects the physical health of patients, but also has emotional, psychological, and social implications. Taking a holistic approach that considers all aspects of a patient's well-being can lead to better treatment outcomes and improved quality of life. And that's what we hope to talk about today. So this is an open conversation again. So those of you who are listening, please ask questions in the chat. With Cindy's help, we'll try to get as many or all of them as we can. So tailored treatment plans, I think that's the initial subject. So when health and wellness are taken into consideration, treatment plans can be tailored to the individual patient's needs and preferences. And this might involve selecting treatments that are better suited for a patient's overall health status, lifestyle, and personal goals. For example, a patient with certain pre-existing health conditions might require treatment adjustments to minimize potential side effects. So I guess starting with you, Dr. Lonial, could you speak to how you might address that and maybe some suggestions that you would have at that initial conversation with your patient, post-diagnosis?
Yeah, thanks, Kenny. And I appreciate the opportunity to be here with you and with my good friend, Dr. Usmani. I think tailoring the treatment means perhaps something slightly different to me than it may be to many in the audience. And that is, we know that there are treatment approaches that, tested in large randomized phase 3 trials, clearly have improved outcomes. When I talk about tailoring a treatment, what I'm going to do is take that large body of data and see how the individual patient responds to that large, broad stamp, if you will, of treatment and make individual assessments there in terms of dosing and frequency and things along those lines. What I worry a little bit about is that when people hear tailored treatment, it means everybody gets something different. And the problem with that is you don't really have the broad experience or data behind you to say this is what in a large population really made a difference. So from my perspective, I certainly want to hear, what are the medicines you're on? What are the medical comorbidities that you have? And I may make a few tweaks initially, but for me, the tailoring really comes in the next 6 to 12 to 18 weeks, where I'm hearing what the patient is experiencing with that standardized treatment approach, and then tailoring it at that point to fit their needs, their lifestyle, and their adverse events in that sense. So I don't know if that makes sense, but that's sort of the way I think about it.
No, I think that's perfect. Dr. Usmani, I mean, are there's some things based on that you're some feedback initially, especially within those first, let's say, for a few weeks, months, specific information that you need back from those patients that sometimes you're otherwise not getting, that allows you to make some of those determinations?
No, I agree with Dr. Lonial's point. There are certain, basic principles we follow in trying to, provide the best control of the disease and get patients into, as good a response as possible. And we all follow those general principles, and the tweaking really happens, on how patients are feeling as they're going through those therapies. But the phases of treatment and the treatments we are giving to the patients, are based on that, the broad level of evidence that we've generated for each of those phases of treatment. I completely agree with Dr. Lonial. And then, in terms of, the advice on their own physical well-being, that really depends on, how much of an impact myeloma has had on their performance status from how they used to be to how they are right now at the time of diagnosis, and that is also dependent on how they respond to treatments, from a disease perspective as well as the safety profile perspective.
So are there anything outside the norm, and I would consider things like, and I know that this is part of it, but data points that would be outside the norm in my mind would be something that should be considered, which is like the emotional impact, psychological impact, things that aren't being done from the patient's standpoint, the things that they need to do, that you need them to do, whether it's to communicate what's going on with them, or to actively do the things that you need them to do in order to make some of these determinations, or go through some sort of assessments. Are there things that would help you do that you're just not seeing enough of?
Sagar, you want to go first?
Yeah. So, I think this, there are a couple of ways to consider this, that question, Kenny. And so the first might be, I always say the stronger you are going into treatment, the stronger you're going to come out on the back end. So when people say to me, what are the kinds of things I can do? My response is stay physically active, try and get to a routine where you're doing more than just sitting in a chair or doing things, try and get back to that and recognize that, yes, the first few weeks of treatment may be a little bit tougher than what you expected, but that is a combination of emotionally dealing with the new diagnosis, as well as a lot of myeloma cells dying. And that in and of itself can cause side effects, fatigue, weakness, that we know that steroids causes muscle weakness and atrophy as well. So there are a number of things that go on in that first cycle or two of therapy that will likely get better over time, but you've got to sort of endure to get through that without making too many changes to the program. And that balance of what is a significant symptom that we do need to make a change to versus what's probably just a response to therapy, fatigue, all those other things, those are balances that sometimes I will try and ride out for the first cycle or two so that I can make sure it is something that we need to make an adjustment for versus something that is going to get better on its own. I think the other thing that often comes up, and I know, Kenny, you probably have things on this later on, or what should I eat, or what supplement should I take, what should I do? And my simple answer, and I know we're going to talk about this in more detail later on, is everything you take has the potential for an interaction for treatment. And we know that treatment has clear data supporting its efficacy for you. The supplements, maybe not so much. And so what I say to people is, I don't know whether that supplement is good for you or not good for you. I just know there's a theoretical risk it can interfere, and I don't want to take that risk early on. So eating a well-balanced diet, being physically active, staying emotionally engaged in the game, because what I always say is that the patients that do the best are the ones that have a reason to get through the treatment. You got to hold on to that reason so that when you come out on the back end, you've got something to go back to. Those are sort of the principles I think about.
Kenny, the only thing that I would add to that is, one thing that, we also pay attention to is, that emotional well-being and the mental health aspect. And, and there is so much variability, in how patients deal with, this life-altering diagnosis for them. And some have very strong, social support mechanisms and people, within their circle that they can talk to and express themselves. There are other patients, who may not be able to do that, where, it actually helps for us to, probe and see if they need help and can have, people to talk to. There's a lot of taboo around mental health in general. And I think this is where, those conversations can help, and opens up, other possibilities of, improving their physical well-being as well. So I think all of, so that particular aspect, is also important during that first couple of months.
Yeah, and I'll step in. One of the things that we at Throwing Bones have been referring it to, so we've created a summary, or daily health summary, that we've been expanding, and we've been turning that more or referring to it more as confounders in the outcome points. So the data points that actually overall impact the overall health of the individual patient, and some of those things are like the basic not so fun things like bowel movements, your sleep, what your hydration level is, those types of things, but also progression of the disease, responses to treatment, side effects, and so forth. And mental health, of course, is one of those confounders. It has a negative impact or positive, but a negative or positive impact on those outcomes is one of the things that we're discovering. So it's hard to quantify that. It's hard to put that. And you were referring to things like supplements. It's impossible to put those things in there because we just don't know. There isn't the research or the data points to support that. So I think that those are excellent points. We did have one question that I wanted to throw in there. It says there have been some studies about patients' microbiome in improving myeloma outcomes. Do you think that this evidence is so significant that patients should attempt to modify their diets to improve their microbiome? Do either one of you have any experience or reference points for that you could comment?
I can, start and Dr. Lonial can comment. One of our very bright, faculty members, Dr. Urvi Shah, is very interested in looking at modifiable risk factors, that lead to disease progression. And, this is where the microbiome, question comes into play. And and Dr. Madhav Dadavkar at Emory, is very interested in this idea as well, because the immune profile of a given patient, is dependent on the interactions with that microbiome, along with the development of the cancer cells. So I think it's all tied in. And we have exploratory data right now, which which tells us that there is a link, and this is a modifiable risk factor. But most of the information we have right now is more exploratory, which means that we think that there may be a link. we are trying to figure out definitively if there is a link, and whether we can modify diets to influence that process. I think in general, the takeaway, when I have discussions with patients, is it's a good idea to participate in those kind of clinical trials and interventions to help us figure out, how definitive that link is. Do things in a commonsensical way outside of those clinical trials. Sagar, what do you think?
Yeah, no, I think that's a great summary. And the only thing I might add is that while we know that there may be a microbiome component to the initiation of a plasma cell disorder, and that's what Madhav is really working on at our place and partnering with others as well. We don't know necessarily how to impact that yet. So understanding what you can do to try and shift that right now is a little bit of a black box. I mean, we're testing an antibiotic in patients with early MGUS to see whether you can change the microbiome in a way that may be positive, to get rid of some of the bacteria that may be at highest risk for inducing an MGUS clone. We're testing that in a clinical trial. I think in the trial that Dr. Usmani was talking about from Dr. Shah, she's looking at a purely plant-based diet for patients with smoldering or MGUS. Versus a regular diet, whatever the patient was on. Those kinds of interventions, I think, are really important for us to understand what is that impact, and is it more than an observation or a phenomena, or is it something you can actually modify? And I think that's the bigger question. Is it a modifiable risk factor or not? And we need patients to enroll on those kinds of studies to really answer that question.
And I think that's a great segue into discussing. You made an introduction to Dr. O'Donnell up at Dana-Farber with me, and I know that Dr. Shah and Dr. O'Donnell are doing a lot in the area of quality of life, and so much of that is that component, and so much of that is also the valid treatment. I think that we're discovering that so much of that is part of the treatment process. In order, or a successful treatment process is focusing also quality of life, not just the cure. So I think that that's an excellent point. Well, so let's go ahead and segue to the next topic, which is optimized symptom management. Multiple myeloma and its treatments can cause a range of physical symptoms such as fatigue, pain, nausea, and more. Addressing a patient's health and wellness can help in managing these symptoms effectively, leading to a better quality of life. Integrating complementary therapies, pain management strategies, and psychosocial support, it can all contribute to symptom relief. So optimized symptom management, what does that mean to you? I guess we'll go ahead and start with you, Dr. Lonial, again.
So I think optimized symptom management is how do you adjust the medicines or the doses in order to try and maintain quality of life, but at the same time maintain some level of dose intensity. And because we know if you come off of everything, then ultimately you're not on treatment. And so, everybody says, well, you've got so many other drugs, why don't you go to something else? You could do that, but if you're playing the long game, you don't want to throw away good drugs before you have to. You want to use every agent in your armamentarium so that you've always got something else to go to over time. And so I think there's a difference between somebody who's going to be on long-term lenalidomide maintenance, for instance, where if you don't make those switches or changes early on, you're limiting the duration of maintenance therapy, which we know has a direct impact on how long patients are in remission, versus cycle 1 or 2 of treatment where they can't sleep and they the side effects are so severe that you're not even going to be able to get the next cycle of treatment in. So I think managing the doses and schedules, and a lot of that is done by our nursing teams who are interacting with the patients when they're coming in for treatment, or are getting messages that are sent in, about some adverse events. And so I think the acute ones you do need to manage to keep patients on therapy, but even the chronic ones you need to think about, because, if a patient is having such bad GI side effects from a medicine that they can't go out, that defeats the purpose of all the intensive therapy we do on the front end, because our goal is to get patients back to their life. And if they don't have that ability, then we need to think about how to make those changes. So that's probably just a start for the conversation.
Dr. Usmani, how about you? What does that mean for you as optimized symptom management? What are you seeing, I guess, in clinic that actually time and again, that the GI actually issue was one of the things that certainly came to me first when I thought about that. So are you seeing other things other than that will require you to think along those lines?
I think, Dr. Lonial has covered this, the answer to this question, very nicely. One of the things that we all talk about is the impact of steroids, on patients as well. And the fatigue and steroid side effect management, I think, is also very individualized. And can impact, the emotional well-being of patients as well. Actually, there are patients, who become, impacted quite a bit from those high, pulses of high dose of steroids, and they'll feel great the day that they get the steroids, and then they'll have, this steroid crash, and that also influences, their activity level, during the subsequent, days after the steroids. But yeah, I mean, all of these things kind of, need to be managed on an individualized, basis in patients. So that's all I'll add, in addition to, what Dr. Lonial has said.
Yeah, and that's actually a really good point. And there's two things leading to a question that was sent by Bonnie, but I often jokingly refer to dexamethasone as the asshole drug, and so sometimes that leads to I guess you could say that's somewhat quality of life issues as well. And those are the things that need to be factored in determining like the reasoning why you're doing it. And so Bonnie's question is sleep is so important. So for relapsed patients, is dexamethasone important for an anti-myeloma effect? Which I'm not entirely sure the that question, but maybe y'all understand what she's asking there. Below what dose is no longer worth the negative impact on sleep? So I actually get that.
Yeah, I mean, I think Dex is a highly effective anti-myeloma treatment, and it also is good in many ways in symptom management. So nausea, for instance, or anticipatory nausea, things along those lines, are actually treated fairly well with a little bit of Dex early on. And so to me, the benefit of Dex in a combination is really in the first 4 cycles. That's where I'm probably going to use it at its highest dose. And if I've got somebody who's had trouble with Dex in the past, I'm not going to start with 40 a week. I'm probably going to start with 20 a week or maybe even lower based on what their tolerance was. The lowest dose that I start to think about, is it really worth it, is probably on the 4 milligram or less dose of Dex, where at that point, you're probably doing a little bit of steroids, but you may not be getting the maximal bang for what you're trying to do. And so that's when I start to taper off or discontinue. But remember, when you're using drugs like, say, pomalidomide or lenalidomide, the IMiDs, their response rate actually doubles with the addition of dexamethasone. So it does have a pretty significant impact on the efficacy of those drugs. When you're using a drug like daratumumab, the Dex in the first cycle is there more so to prevent infusion reactions. So once you get past the first few doses, the likelihood of needing big Dex, unless you're partnering with an IMiD, is lower. So there are a lot of subtleties and nuances here, but I think the idea of continuous high-dose Dex or low-dose Dex, depending upon whose nomenclature you want to use, beyond 6 months of therapy really doesn't make a lot of sense. And that's something where I think patients can be more involved in their care and say, do I really need the Dex at 40 milligrams? I'm cycle 7. And the answer should be probably not. We can be tapering that down, but that's where they can help in managing their care.
Okay, well then let me go ahead and move on to the next one. I'm going to get to our poll question in a minute and just share the results with everybody when we get a little bit closer to nutrition and exercise. But the next one is about enhanced psychological and emotional well-being. A cancer diagnosis is like multiple myeloma can take a toll on a patient's mental health. I don't know many cancer patients who haven't dealt with some form of depression or anxiety post-diagnosis. I haven't met many or any. Focusing on wellness involves providing psychological support, counseling, and resources to help patients cope with anxiety, depression, and stress. A positive outlook and strong emotional well-being can positively influence treatment adherence and response. So based on that, how often do you encounter patients that you have to sort of navigate that arena where their psychological and emotional well-being has impacted your treatment of the patient? And I guess let's start with Dr. Usmani, since we've started with Dr. Lonial.
So, I think, we touched upon this, in one of the earlier answers. I think, that whole emotional well-being component is extremely important, and also, dependent on, patients' own preferences on how they have dealt with, stress situations in their lives in the past, what kind of social support mechanism they have. And you have to take a lot of these things into account, and engage the resources you have, with social work, any clinical psychologist that you may have access to as part of your cancer centers, supportive care departments, but engaging them early, would be the key. And many times, many patients start focusing just on the disease aspect of it, and then, the emotional part hits them a bit later. But having that engagement early on is very important. And many times I've found our social work colleagues to actually, do a really good job in identifying, the patient phenotype, the kind of, resources that a particular patient may need. Um, and um, and this is where, the role of caregivers also comes into play. What kind of support mechanisms they have, the kind of um, support that the caregivers can provide, to patients also varies. So recognizing all of those things, is a little bit complex, and perhaps, more tailored for every patient.
Yeah, I agree. I think this to me is probably one of the most impactful areas in terms of how to manage a patient. And the patient that comes in that is sort of depressed or beaten down, or again, their head's not quite in the game, is a much more challenging patient to get through therapy than a patient who is otherwise. And so I think paying attention to that, listening to family members who may be raising these red flags, getting them connected with psychiatrists who are directly focused on dealing with this in a cancer patient population. It's very different from a general psychiatry patient. And I know that Saad Center and our center have people really dedicated to this, is really critical to being able to get where you want to get, because people that don't have strong emotional well-being coming into treatment or during treatment are going to have a lot more toxicity, a lot more. In many ways, they behave. Their response is a lot like a frail patient, and it's very hard to get them through therapy. And this is in no way a value judgment. I just think it really raises up the level of importance that we need to pay to people like this to make sure we can get them through. As if you may not get another shot if you can't address that and you can't turn it around in an appropriate way.
It seems to me that patients where you struggle, so the bulk of this conversation is supposed to be centered, of course, on the patient and the things that are helpful from a transformational, holistic standpoint. But it seems to me that we potentially miss out on patients, or some slip through the cracks, or maybe a lot slip through the cracks, who don't get the same level of treatment because they don't have the same home base, they don't have the same social network. they don't have the same caregiver opportunities that other patients do. And so not only do they not potentially get the same level of care, but they also take more resources potentially from their care providers, because you'll have to focus, you as the healthcare provider, excuse me, have to focus more energy on them to get them to the same level as those who might come in with a different emotional or mental wellness approach. Are there any things that you can initially look for in that to try to ease that transition, to give them the opportunities to maybe even the playing field for them?
But, again, I think the keys are, what are the pieces to being successful? And I think getting a good sense of what does the short-term and the long-term plan look like is always helpful, because I think there's a big degree of uncertainty with what's coming in the next few months or weeks or days. And so providing a plan, I find, when I see a new patient, I say, well, here's your 3-month plan, here's your 6-month plan, here's your 10-year plan. That goes a long way to them being able to understand and then begin to think about how they can impact their outcomes in that context. Every patient, again, comes in with, should I not eat sugar? Should I eat this? Should I eat that?
Right.
Giving them some concrete answers, not necessarily saying you should or shouldn't, but just sort of say, here's what the data looks like. I know you're going to come to this because this is one of your favorite parts of it, but the whole impact of exercise and activity, critically important. I mean, if nothing else, exercise gives you endorphins that at least help try and lift you above all that, in addition to all the other things they probably do from a physical well-being perspective that help you get through treatment more effectively. So I think it's a number of factors there. And you're right, you may be spending more time initially trying to get them where they need to be, but it's incredibly gratifying when you can see that turnaround happen. And what we have to be careful about is how much of this loss of well-being is a consequence of therapy. We know that steroids cause depression. We know that the IMiDs can sometimes cause neurologic side effects like confusion or lack of mental clarity. Being able to tease that out really does represent a little bit of a challenge on our side. And we need to be open to the fact that we may be causing this problem.
Yeah, well, and so I'll go ahead and jump to that next one. That's a good segue. So nutrition and exercise. A balanced diet and regular exercise can play a crucial role in a patient's overall health during and after multiple myeloma treatment. Proper nutrition can support the immune system and help manage treatment-related side effects. Physical activity can improve muscle strength, reduce fatigue, and contribute to overall well-being. And we just had a poll up to say, have you changed your nutrition post-diagnosis? And 70% of our participants today said that they did change it, which is interesting, I think, from my perspective, because I'm not sure that there's certainly lots of folks who will contribute their expertise on what it should be, which includes those supplements that you mentioned earlier, you talked about earlier. But sometimes it's not always certain what that means, what the best thing is to do. So what would be your initial approach when talking to a patient about nutrition and or exercise, despite what, in addition to what you've already said, encouraging them to do what they can, increase their activity level, healthy activity level? What are some other things that you might start with in discussing nutrition and exercise?
So in
Dr.
addition
Usmani.
in addition to what Dr. Lonial stated, I think this is where you have a lot of flexibility in the kind of advice you can give to patients, because how our patients are presenting is quite variable. There might be patients who had significant bone fractures at the time of diagnosis that may get in the way of them being more active early on, and that level of activity gets better. So you have to kind of pair the enthusiasm to be more active with what patients can really accomplish, and make sure that they don't get themselves down by saying, oh my God, I can't do what I used to do, or I can't get to where I need to get. So I think that's the balancing part of it, and so I think that discussion has to be individualized. I think from the nutrition perspective, again, I think that there are resources that Dr. Lonial's, and I have at our disposal at our respective cancer centers where we can, engage, nutritionists to help, patients in picking the right, making the right nutritional choices for themselves. Many of our patients may have other comorbidities or diseases that influence that as well. If you have diabetes or significant hypertension requiring you to be on say a low salt diet, etc. So this is where I think there is a lot of individualization or personalization that we can do. And many patients, just like Dr. Lonial said, as you talk about both the short-term and long-term goals with patients, I think it's important to even break down the physical well-being and health into that short-term and long-term goal with them, and help them focus on what's important during the induction phase of treatment and or transplant, etc. If they're eligible for it, versus in maintenance they're going to have a longer segue into getting to where they want to be.
Yeah, I mean, I think when you say you need to be more active, it doesn't mean go out and run a marathon. And what I tell people is walking every day is probably good. If you're out walking 2 to 3 miles a day, I think that's good. And when people say, well, I don't have, how do I know where I'm going or how far I'm going? I mean, the iPhone app gives you an easy way to measure your number of steps. And so if you're thinking about, how far am I really going in a day, that's an incredibly simple way to know maybe I should do a little bit more walking this afternoon, or maybe do a little bit more in the morning. And it's not expensive. You don't have to have a membership at a gym to be able to do that. I think stationary bike is another way to do it. Again, you don't have to push your heart rate to 150 to 160. You just need to do it for a period of time in order to sort of keep the joints moving and feel like you are getting your heart rate up a little bit. It doesn't take a lot to be able to do this and still get the physical well-being that you need, as well as the positive impact on mood and other things that I think really do ultimately help. And I think all of us have those days where you're just exhausted by the time you come home, or you've been in clinic all day, or you've been doing this, or you've been doing that. And, just 20 minutes doing something is enough to help you shed some of those burdens and clear your mind to be able to tackle whatever's next in front of you.
I think that's, yeah, absolutely, really well said. And one of the things that I say in a lot of the talks that I've given over the past couple of years, and one thing that I do to my coaching, my clients as well as my athletes, because I do coach various athletes on the side also, is there are days when you need to just be able to put your shoes on. And that's the start. And usually that's the beginning of get yourself out the door, or to the treadmill, or on the bike, or whatever it is that is something that's getting you active. So the beginning stage is really the most important one, starting. So tie your shoes, get out the door, and the rest is gravy. Plus you've had success. You measured success by doing that. If that was your goal, you did it. And then you get to improve from there. And I think that actually leads to sort of the mental health aspect in order to getting yourself to the next stage. Like when I'm doing something positive towards my treatment. And you're right, that is one of my favorite topics to talk about, because I think it's such an impactful way to take control of cancer treatment. At least from the patient standpoint, it's something that I control. And I know Dr. Usmani's a big proponent of this too, because he practices what he preaches. He just got back from the Berlin Marathon, so congratulations on doing that. That was fantastic. And I know that you in the past you have run with your patients even during marathons, and so that's fantastic, which is certainly another way to encourage them to do that, to see the things that they can do. And again, like you say, that doesn't mean that you need to go out and run marathons or ultra marathons, or even 5Ks for that matter. It's doing what you can that's within your boundaries and testing your limits and expanding those to the beyond to make yourself better and more successful. So moving on, unless there's, and again, I could talk about nutrition and exercise for a long time and the value of it. But I think social support is another thing that I kind of touched on before, that I think it's a really insanely valuable component, and also one that sometimes separates patients. There's there's a disparity within treatment world, and see people who even seek treatment because of the lack of social support. Engaging with a patient's social network, including family, friends, and support groups, can provide emotional and practical assistance. Strong social connections can alleviate feelings of isolation and help patients navigate the challenges of treatment. That's an essential point in my mind, just starting the process of seeking treatment for whatever. And so if a patient's first introduction to multiple myeloma is through some sort of bone involvement, organ involvement, fatigue that led to blood tests, which seem to be more common from what I understand. Sometimes taking that next step to determining what the problem is, and then maybe even treating it with or seeing a specialist, which in most areas there is not one. A specialist that focuses on multiple myeloma. In a lot of rural areas, or even just, let's just say where I live in Asheville, North Carolina, we don't have a myeloma specialist, lots of hematologists, but nobody who specializes exclusively in this disease. So how do you activate patients that are coming from that world where they don't have the social support, they don't have the encouragement, they don't have a caregiver who can listen when they're being given instructions by their specialist, if they even get that far? Because I have a feeling that a lot of them who might be doing this solo are so overwhelmed with the process, with the industry speak, with the medical terminology, the different drugs that are up. And again, that's a big thing too, because 10 years ago, the available first-tier treatment options were significantly different than what they are today. So how do you involve that patient? Dr. Lonial, how do you start with a patient like that?
Yeah, and the first thing to do, and you can often tell this at the consult visit when they may come alone to the consult visit. And the first thing I often will say is there somebody else you want? Is there somebody in the waiting room, or is there somebody you want on the phone while we're talking? Because when you're meeting an oncologist or a specialist for the first time, I'd say 50% of what is said to you, you may not remember because you're processing it, you're by yourself, you're dealing with it. And so I think the first thing is make sure you're not alone in those initial encounters. And if you don't feel like you have the social support network, it doesn't have to be a family member. It can be a friend. It can be somebody from your church. It can be somebody from work, somebody from whatever sort of social interactions you may have. But bring somebody with you, and recognize that it may seem like a burden that you're asking them to come with you, but 9.5 people out of 10 are not even going to think twice about saying yes to something like that, because they recognize the importance of that presence on your outcome. And so getting over the fear of asking for help is sometimes a hard first step, but it is critical, I think, Kenny, as you point out, not just in terms of initial treatment and getting the right support to get through it all, but many of the treatments we have now, like bispecifics or CAR T cells, almost require a level of social support that is very different than some of the things that we've done in the past. And so if you don't have it, working to get it quickly is, I think, really important. And I know that part of our, for instance, our transplant workup is that our transplant coordinators and the social workers will explore this question specifically with patients to understand who is their social network, what are the people they can call on, because you'll need some caregivers during the process to be able to get through this. So if you haven't done it already, I would encourage you to do it early, so that you can have that network around you to help get you through the tough days. The good days, everybody can get through the good days. It's the tough days. You need those people around you to help hold you up and get you where you need to be, and help you manage symptoms and side effects, and help you call and get help when you need help.
Yeah, in addition to, all the, great points that Dr. Lonial made, I think, um, uh, both our cancer centers have access to, patient support resources, and many, patient advocates, who are willing to actually reach out and provide, a resource to, patients, who are newly diagnosed or maybe struggling with their diagnosis, or require emotional support and advice. And that is another, resource that is, not well, it's not utilized by many patients, but it can be. There is inherent hesitancy sometimes in patients in sharing their stories, or trying to learn from other patients' experiences. But I think that is becoming more of an acceptance by patients at large. And so, if there are patients, in less populated areas, or where they do not have access to a myeloma specialist, now you have patient advocacy groups, such as your organization, Kenny, as well as others like IMF and MMRF and HealthTree, that each dealing with patient advocacy in different ways, and focusing on different things. But there are all these resources out there that can provide that support to the patients.
That's actually a good point about how different treatment plans require a caregiver to be part of that. I know that CAR T, and I don't know if this is true across the board, but from my understanding, that just about all of them require a caregiver to go through some process at the beginning of the program in order for you to, I guess, really be eligible for the CAR T in itself. Is that you have to present who those caregivers are or will be, and they have to actually show that they will be a part of the process, for all sorts of reasons, and the emotional part is part of it. Now, one thing that concerns me is requiring those things potentially leads to leaving some patients out again of the process, and so yeah, I think that I hope that so many of your institutions, as well as other organizations, advocacy organizations and groups that have things, so like HealthTree has the myeloma coaches, that's certainly an opportunity at least to engage with other folks who have either gone through the experience or at least experienced enough to where that they can be a part of the solution. Those are out there. I wish it was more mandated, honestly, because it concerns me that there are plenty of patients that are so overwhelmed by the process that choose to not do anything. And so there again, there is a group of patients who are less than, in some ways, and they don't get to receive the same level of treatment as others because of that. So shared decision making, we're actually moving through this list pretty well. I'm gonna go ahead and move into that, and actually, you know what, I'm gonna back up one time, because there actually is a good question on here that I wanted to throw out at y'all. It says, Dr. Usmani spoke of Dr. Arisha, and you have been speaking about nutrition at Memorial Sloan Kettering, and it has a website on herbs. I said, what about this? The question is, what about supplements, curcumin, vitamin C, omega-3s, especially for patients on IMiDs? Are there specific supplements recommended to fight myeloma and or drug side effects? Either one, take that.
So I think any supplements taken in commonsensical doses are okay, but I typically don't advocate mega doses of vitamins or other supplements, such as vitamin C, or curcumin and turmeric. I think if taken in reasonable amounts, whatever is the daily recommended dose, I think that's reasonable. And I don't think taking curcumin or turmeric would impact the general well-being, or interfere with whatever treatments patients are taking. I joke around with patients about this, that Where I come from, our people have been, doing this for centuries, and it's totally okay to do. But we're not sure whether there is an impact on, the progression of disease or impact on the overall outcomes. But, I think it's reasonable to do. There's nothing wrong with it.
Yeah, I mean, I think there are 2 points I'd make, particularly about the ones listed in the question. The data on curcumin and turmeric in randomized trials have not borne out any response. There are a couple of places that have looked at that, but I think to me the bigger question about those two is that both of them work by inducing changes in the myeloma cell metabolism and survival that ultimately in vitro may result in killing myeloma cells. In order to absorb enough curcumin or turmeric to even get to measurable blood levels, you have to eat kilograms per day, which even in Indian food, you don't put kilograms per day. So I just, those are things that I think you end up eating and just excreting without really being able to have much of an impact. Vitamin C is actually a really interesting story because this is a great example of why cancer centers are so interesting. So one of our basic scientists who works in lung cancer actually looked at the structure of vitamin C and then the structure of a proteasome inhibitor and said, I wonder if there's going to be an interaction here. And years ago, this data is probably 10 or 12 years old now, actually took vitamin C and put it in cell lines with myeloma and bortezomib and showed you could completely block the effects of bortezomib on killing myeloma cells. And we said, well, great, that's a high-dose vitamin C question. It's in vitro. Is it really relevant? We then the group in Boston took patients who had taken an over-the-counter vitamin C supplement, took their plasma and added it to cell lines of myeloma cell lines and bortezomib. And even that low dose blocked the effects of bortezomib. Those are the ones we've tested. There's so much out there we haven't tested that we don't know. That sort of is the reason why my stance is, if you don't know, I would recommend not doing it. Not because I think it's bad or it doesn't work. We just don't know. And I'd rather not take a risk on limiting something that I know has efficacy based on trials. So that's, I think, an important highlight there.
Yeah, no, that makes a lot of sense. One follow-up question about the caregivers and support and so forth, and then we can move to shared decision making. But the question was, do doctors permit patients to record their meetings or allow someone to participate by phone in the meetings with the patient? And I think actually, Dr. Lonial, you had already said that. Is there somebody that we should call during this meeting?
Yep, I do, and I'm sure Saad does too.
Yeah, I mean, it's very reasonable. In fact, we encourage this because, many times, things that we communicate to patients, may not register. So it's a good idea for them to have that recording that they can go back to. And sometimes, patients have questions that come through our, electronic portals, about, hey, I was listening to this conversation, just wanted, this point of clarity, or it might come up, in the next appointment. And I think it's very reasonable to do that.
And assuming that we have patient involvement or engagement where you're able to access the patient's understanding, where they're not so overwhelmed that they shut down and they are hearing you, involving patients in decisions about the treatment and care is essential for their overall wellness. We've already talked about that. When patients feel empowered to make informed choices, they are more likely to be satisfied with the treatment journey and experience a better quality of life. So could we talk about that for just a minute? And what is it that maybe we could, how much more can you encourage patients to do that? And what are some ways that maybe you can encourage them to become a part of the process without being overwhelmed by it?
I guess, that also depends on, how much patients want to, how much depth they want us to go into. And we're always, open to, explaining things going into the nitty-gritty as much as possible, but it also depends on patient preferences. That there are patients who would like to know the things in more generality, in terms of the bigger picture. There are other patients who would really like to go into the depth of data and actually talk about percentages and numbers with us. But you have to provide whatever the patients are comfortable with, and helps them in making that shared decision on what kind of therapies that they're going to need. And so you just have to feel that out from those patient interactions. Many times it could be the caregiver who is actually deciphering all that information to them. And that happens after that clinical interaction that you've had in the office.
Yeah, I don't have anything else to add. I think Saad's response was pretty good. I
Okay.
agree with the same thing.
Yeah, no, and I think a lot of that we've actually covered previously anyways, and including the patients in the process is essential if possible, because again, you're unable to do your jobs if you don't know and you don't hear from them. And if they don't understand what's going on with them or to them, then they certainly can't be a part of that process. So with and one thing I will point out, I know there's been a question, somebody raised their hand. If you've got a question, please make sure you put it in the chat. It's a lot easier than in trying to pull you into the conversation. Just throw that into the quick Q&A and we'll make sure we get to that. So lastly, let's end this on a good note. And this is kind of a combination, but long-term survivorship. For many multiple myeloma patients, the goal is not just to survive, but to thrive after treatment. Prioritizing health and wellness during and after treatment can contribute to better long-term survivorship outcomes, including reduced risk of disease recurrence and improved overall health. And so how much of that play anymore into your treatment initially as well as ongoing, when concerning relapsed patients that come to you, but how much of that plays into your thought process, their long-term survivorship?
I think it plays a very important role, because, what we're thinking about from the get-go is the long-term game plan. So, we're already thinking, 2-3 steps ahead, and that plan does change with time, as new information comes into play. But, you do have a general idea of what that overall game plan would be. Myeloma has become, a marathon for more, majority of patients, where the disease is chronically managed. And the nuances of coming up with a game plan for, patients who have, standard risk kind of disease versus, high risk disease is a little different. But yeah, I mean, all of those things we pay attention to.
Yeah, I would agree. I mean, I often tell my patients I'm taking the 10 to 15 year view in terms of what's going on. And so when people say, well, you can do a transplant or not do a transplant, the overall survival is the same, they're missing the point. If at 7 years you've gone through 3 different regimens, and yes, your survival is the same as a patient who had a transplant and went through one, you've already gone through 3 times as many drugs as you would have with the one. And so, yes, the survival looks the same. The remission duration is not, and you're now on 4th-line therapy sooner than you would have had to be had you taken full advantage of all the treatments. So there is a role for shared decision-making. I think that was part of one of your questions as well, Kenny. And that's important, making informed consent decisions. But you need to have all the data in order to do that, and making sure you've got an advocate that is taking the long view of your care, as opposed to, well, what are we going to do for the next 2 years? You don't need to do a transplant because this regimen X will keep you in remission for 2 years. 2 years isn't enough. Right. I would argue 5 years isn't enough. And so that's sort of the methodology behind why I think the way I do and what I do what I do.
Well, that's fantastic, and I know that we were pushing right up against the time. And Dr. Usmani, I know you have another call shortly, so I'll go ahead and wrap up now. And any opportunity for any final words before we finish? We'll start with you, Dr. Usmani, since I know you've got to run.
No, I think, thank you for taking the time and engaging us on this extremely, important, topic. We need to talk about this, more with our patients. And I hope that, the discussion will help not just the people who've actually signed in right now, but for others, who will, be able to see this content online later on. Thank you for inviting me, Kenny.
Thank you very much for being here. Dr. Lonial?
Yeah, no, I think this was a great opportunity to talk about things that we don't, at least I don't often get asked to talk about. And I may not know all the data, I may not know all the answers, but I know it's groups like yours and people like you who are setting examples for what many of our patients can be doing. At the end of the day, this kind of work really helps everybody take better care of the patient. So thank you for what you're doing.
Thank you very much. Incorporating a patient's health and wellness into the treatment plan requires a collaborative approach, and you're part of the solution. So thank you being part of everybody's support network. So hope you both have a fantastic week, and we'll be talking to you soon. Thanks for everybody participating, and we're signing off now. But we hope you'll come back for more panel discussions.
Thank you.
Bye-bye.
Bye.